Parkinson's psychosis, and some of you may have heard me speak on this topic before. Parkinson's disease is a pet disease of mine, if I need to call it that, because my husband's family has a significant number of people within his family that have suffered from Parkinson's disease. Most recently, his father passed away with complications of late-stage Parkinson's disease, and he actually did have Parkinson's disease psychosis. So although I have been studying this disease and this particular aspect, non-motor aspect of Parkinson's disease for a number of years, it was disappointing to see someone that I'm related to actually develop so many of these symptoms. And he did get treatment with the #1 drug to treat Parkinson's disease psychosis. In fact, it's the only FDA-approved drug. We'll go over that today, and we'll also go over some of the research of new products that are being investigated for use in the treatment of Parkinson's disease psychosis. And we're going to get all that done in probably 40 minutes, so let's get started. So we're going to describe the psychiatric symptoms of people with Parkinson's disease. Again, our focus today is going to be on the psychosis, which can be present in up to 50% of people with Parkinson's disease throughout their lifetime with Parkinson's. And then we'll talk about, again, pimavanserin and some of the other available off-label treatments, and then some of the investigative treatments that are currently under research. So, and this is me, everybody knows me. I am a speaker for Acadia, so I have had some experience speaking on Nuplazid, which is pimavanserin, but we're going to talk about a variety of topics, both on-label and off-label today. So just to get started, Parkinson's disease, just to get us all level set, we have traditionally thought of Parkinson's disease as a motor disease. We think of it with the cardinal symptoms, which spell out the word TRAP. It's tremor, rigidity, akinesia or bradykinesia, which is slowness of movement, and postural instability. And you can see in the gentleman depicted over on the right-hand side of your screen that they develop this stooped posture, and they also have a postural hypotension aspect of the condition that puts them at high risk for falls and injury. But it's actually, even though tremor is oftentimes thought of as the primary symptom of Parkinson's disease, up to 30% of patients with Parkinson's, in fact, do not ever have a tremor, or they may not have a tremor until the very late stages of Parkinson's disease. So the #1 most recognized feature of Parkinson's disease is rigidity, stiffness. But we've always said if you're slow and stiff, we've just assumed people are old, right? You get old, you get slow and stiff, but slowness and stiffness may actually be a symptom of Parkinson's disease. So I encourage all of you to evaluate your patients, your residents, for the presence of Parkinson's disease, because we may have people that we are treating who may not have a diagnosis of Parkinson's disease. Oftentimes in our long-term care facilities, it's the Parkinson's disease psychosis that even brings awareness of Parkinson's disease to the forefront. So the common motor symptoms also include mask-like expression, which is sometimes confused for depression, but you can also have depression and anxiety associated with Parkinson's disease, a slow voice, drooling, reduced blinking. It turns out my father-in-law never had a tremor, even though he lived with Parkinson's disease, diagnosed for 10 years. His first symptom that led him to go to a neurologist was reading a newspaper and noticing that he was having drool drop on his newspaper. And that was his symptom that he recognized that led him to a neurologist for the diagnosis. So these other motor symptoms can be quite common, and in fact may be more noticeable than the cardinal symptoms over on the left. So we also can recognize if someone might have Parkinson's disease by the medications they take. So the common medication is levodopa, carbidopa, and then you may also see dopamine agonists and COMT inhibitors and MAOB inhibitors. So we're not going to talk about Parkinson's disease and treatment today. We're going to talk about psychosis, which is actually one of the common non-motor symptoms. So you see over on the right-hand side that cardiovascular symptoms, including falls, can be a part of a non-motor aspect of the disease. Mood and cognition, sleep and fatigue, gastrointestinal slowness, urinary incontinence, sexual dysfunction, all of these can be problematic with Parkinson's disease. And it's oftentimes the non-motor symptoms that show up first. So I love this graph, which is the time and years that we have mapped the symptoms of Parkinson's disease. So you can see that about 20 years before the disease gets diagnosed, people will start having some of these non-motor symptoms like constipation. So an increasing constipation can be a symptom, a prodromal early symptom of Parkinson's disease, but so many people just also relate increasing constipation to aging. REM behavioral sleep disorder, the RBD, starts about 10 years before the average Parkinson's diagnosis. REM behavioral sleep disorder is where someone starts acting out on their dreams. Excessive daytime sleepiness, or EDS, well, obviously, if you're not sleeping well at night, you would tend to have excessive daytime sleepiness. And depression. Those tend to happen a few years before the diagnosis of Parkinson's disease. And then finally, at diagnosis, you begin to see those cardinal symptoms. But as the disease progresses at about 10 years into the disease, we begin to see psychosis develop. And this psychosis is very specific for Parkinson's disease psychosis. It's different than many of the other types of psychoses that we see in dementia and just basic psychotic illnesses like schizophrenia or schizoaffective disorder. So we know what's going on in Parkinson's disease. We all learned that in pharmacy school, that it's characterized by a loss of dopamine neurons in the substantia nigra and the presence of Lewy bodies. This is the classic slide we all got shown with Lewy bodies that you can see on slides of brain tissue, and then you can also visualize it with a loss of the brown pigment in the substantia nigra. But the thing that they didn't teach us in pharmacy school is that when Parkinson's disease develops, Lewy bodies are actually present throughout the brain. They are diversely and uniformly deposited throughout the brain. They are not just in the substantia nigra of the basal ganglia. So it's the presence of these Lewy bodies throughout the brain that we believe causes a hyperactive dopamine in the mesolimbic system. So that's the dopamine theory. A hyperfunction of the serotonin 2A receptor in the cerebral cortex, which we will see in a few minutes, can lead to both the visual hallucinations and the increase in dopamine in the mesolimbic system. And then a hypofunction of glutamate. So we think there are actually 3 neurotransmitters that are impaired in people that develop Parkinson's disease due to the diffuse presence of Lewy bodies throughout the entire brain. And these different neurotransmitter theories are all being investigated for the potential to treat the psychosis associated with Parkinson's disease. This is sort of a graphic depiction of what the proposed mechanism of action or mechanism of disease of Parkinson's disease psychosis is. So what we're dealing with is a loss of serotonin neurons, because the Lewy bodies, when they start to deposit throughout the brain, they are depositing in the Raphe nuclei, which is sort of the interstate system for serotonin transport throughout the brain. And the deposition of the Lewy bodies and the body's response to Lewy bodies as a foreign object causes an overall loss of serotonin neurons in the Raphe nuclei. However, when that happens, there is a compensatory upregulation of serotonin 2A receptors in the cerebral cortex. And that has been shown through various mechanisms to cause visual hallucinations directly with this upregulation of serotonin 2A receptors in the cerebral cortex. So this upregulation of serotonin 2A results in a downregulation of GABA aminobutyric acid and a compensatory upregulation of glutamate. And then that upregulation of glutamate goes to the ventral tegmentum area, which is the mesolimbic system of the brain, and it causes an increase in dopamine. So this is sort of contrary to what we all learned about Parkinson's disease, because when the Lewy bodies are in the basal ganglia, we see massive loss of dopamine-producing neurons. So we've always thought of Parkinson's disease as a disease due to loss of dopamine. And we often, we use levodopa as an artificial dopamine or dopamine precursor to treat Parkinson's disease, and the carbidopa prevents it from being broken down in the periphery, so it gets into the blood-brain barrier. But we're giving people with Parkinson's disease dopamine, which in areas of the brain, particularly the basal ganglia, helps to improve the motor dysfunction. But it can worsen the psychosis that's already happening. Now, people that have Parkinson's disease that have not started on levodopa, that are dopamine naive, they're not taking any Parkinson's direct medication, they can still get this psychosis because the overactivity of the dopamine in the mesolimbic system is actually thought to be caused by Lewy bodies in the serotonin system. So this is the proposed mechanism of action, and it incorporates all three of those neurotransmitters. But right now, our treatment that we have available to us is working primarily to downregulate that serotonin 2A receptor in the cerebral cortex, because if we can stop that cascade of events from happening, then we might be able to reduce or prevent the psychosis. So that's the thought. So I have a question, and you guys can answer this in the chat. I'm going to open up the chat in just a minute. Question number 1. The pathogenesis of Parkinson's disease includes the imbalance of which of the following neurotransmitters? Dopamine, serotonin, glutamate, or is it A and B, or is it all of the above? So just jump into the chat and tell me whether it's A, B, C, D, or E. And I'll just watch the chat. And yeah, everybody has paid attention so far. The correct answer is E, all of the above. So yes, all three of them are involved. Let's get back to our talking about the treatment. So we really know that Parkinson's disease psychosis should be something you're looking for, particularly if you work in long-term care, or you work with people that are on the second half of their disease process. So we know there's probably about 1.5 million people in the US living with Parkinson's disease. The Parkinson's Disease Foundation still says 1 million, but we know that that's an increasing percentage of overall neurodegenerative diseases. Parkinson's disease is now the second most common neurodegenerative disease. And about half of people with Parkinson's disease will develop the psychosis, and it tends to develop in later stages, which is sort of the time that people get admitted to the nursing home. Looking at MDS data in our nursing homes, 5% of our nursing home population has a diagnosis of Parkinson's disease, but that could be a much higher prevalence, and they are just not yet diagnosed, since many people don't go to the neurologist until they get a tremor, and that can happen at the very later stages of the disease. Now, there was a study looking at when people develop Parkinson's disease and the psychosis. In the beginning, oftentimes the symptoms of psychosis, visual hallucinations, are usually the first thing that happen. They are not problematic for the resident or the patient. The patient may realize that they're seeing something that's not there. They have insight into their hallucination, and they may not be bothered by it. Maybe they see a loved one that has passed away. One of the study participants, when Nuplazid was being investigated for PDP, Parkinson's disease psychosis, was a lady who, when she went to bed at night, she saw her dead husband standing and watching over her. And in the beginning, she felt calm, she felt protected, she felt that her husband was like a protective angel coming to take care of her while she slept. And you can have this insight in the beginning, but the study that I have showing here, the GET study, indicates that 81% of patients that start out with benign hallucinations that aren't really bothering them will progress to losing insight and having scary hallucinations, or to frank delusions within 3 years. So just about everyone who has a psychosis associated with Parkinson's disease will progress to being troubled by this psychosis. In our nursing homes, they tend to already be troubled by their hallucinations or their delusions. And this can cause agitation, it can cause them to be disruptive, it can cause them to not allow the caregivers to provide care, to fight when they try to bathe them. So this can be very problematic, not only for the resident or patient themselves, but also for their caregivers. So let's explore this a little bit deeper. I mentioned that visual hallucinations are often the first psychosis symptom that people with Parkinson's disease have. And you can see up to 72% of people with Parkinson's disease psychosis report having visual hallucinations. Commonly, people will see children or they'll see animals, although they can see anything. But frequently in our nursing homes, we hear of residents that are reporting that they see children in the hallway, or they see children in their rooms. Most of the time, there's not an auditory component, but up to 22% of people can have an auditory hallucination as well. And a lot of times the auditory hallucination is in context with the visual hallucination. So if they're seeing children, they may hear them crying or laughing or calling out, or if they're seeing an animal, they may hear it meowing or barking. So those are the most common visual types of hallucinations that people report. You can also have some of these other types of hallucinations, but they're much less often. As the disease progresses and the psychosis progresses, then we see the development of delusions. And the delusions are also very common. So visual hallucinations, they tend to occur most commonly in Lewy body disorders. So in Lewy body dementia, Parkinson's disease with Lewy bodies, we tend to see this visual hallucination very commonly, and delusions. And the delusions are often jealousy, like they believe that their loved one, maybe their spouse or significant other, is having an affair. In our long-term care facilities, if the spouse is not living with the resident or patient anymore, they may not have the jealousy delusions, but they could still be persecutory, like they think someone is trying to steal from them or has stolen something, or someone is threatening them harm, or a delusion of reference where they hear something on TV that has nothing to do with them, but they think people are talking about them, or they overhear a conversation in the hall and they believe it's in reference to them. So these are the types of hallucinations and delusions that you will usually encounter. Now, I haven't discussed this yet. I want to see if you guys know this already. What makes an antipsychotic atypical? We're going to treat psychosis typically with an antipsychotic, and we have typical and atypical antipsychotics. So what makes an antipsychotic atypical? Is it because it's discovered after 1995? Is it B, that serotonin 2A receptor affinity is more potent than dopamine receptors? Or C, is it the opposite? Dopamine is more potent than serotonin affinity? Or is it D, an indication as adjunctive treatment for resistant depression? So what makes an antipsychotic an atypical antipsychotic? Let me open up the chat and see. All right. My work is done here. You guys, I haven't even addressed this and you've already answered it correctly. So the correct answer is B, serotonin 2A receptor affinity. And that's important for treating Parkinson's disease psychosis, because if the issue that is the beginning of the cascade of events that causes the psychosis is overactivity of serotonin 2A receptors, then an antipsychotic that focuses on blocking the serotonin 2A receptor would be the appropriate choice to treat Parkinson's disease psychosis. And ideally, we should select an antipsychotic that only focuses on blocking serotonin 2A receptors and does not block dopamine receptors. Remember, we are treating Parkinson's disease by giving the individual an exogenous dose of dopamine, and that's so it can get to the basal ganglia and correct the motor dysfunction. But if we also give them an antipsychotic that is blocking dopamine receptors, then obviously we are in a therapeutic bind. We're preventing the activity of levodopa-carbidopa. Doesn't make sense. Although I have to say, I've seen Parkinson's disease patients treated with antipsychotics that was blocking their dopamine receptors pretty much for the last 40 years. So even though it doesn't make sense, we still see it done. For many years, we didn't have any other choice. Today, though, we do have an antipsychotic that works by only blocking serotonin 2A receptors. So this is a slide that was developed by Stephen Stahl, and I borrowed it for this presentation. I absolutely love the way that he depicts receptor binding for different compounds. And this is antipsychotics in general. And you can see that antipsychotics, some of them block all of these receptors, some of them are only blocking some of these receptors, but antipsychotics can block different receptors and they can have an adverse effect profile based off of what they block. You see the serotonin 2A receptor is the big rectangle with the red outline, and the D2 receptor is the big triangle with the red outline. All antipsychotics will block either D2 and or the serotonin 2A receptors. In order to be an atypical antipsychotic, you have to block serotonin 2A. So we did have some original receptors that had very little potency at serotonin 2A in our original typical antipsychotics. But with the atypicals that came out originally with the risperidone, they started having more activity at the serotonin 2A receptor. But just as a reminder, if you block muscarinic receptors, your adverse effect profile would be cognitive impairment, which is often also going on as a non-motor symptom of Parkinson's disease. You can have disinhibition, mania, antisocial behavior, euphoria. You can have some cardiovascular complications, and you can cause constipation, which cardiovascular complications and constipation also happen as non-motor symptoms of Parkinson's disease. So giving an antipsychotic that blocks muscarinic receptors can worsen non-motor symptoms. And if it blocks the D2 receptors, it worsens the motor symptoms. If we give an antipsychotic that blocks histamine receptors, we can cause sedation. If we give an antipsychotic that blocks the alpha receptors, we can worsen orthostatic hypotension, which can be happening when people have Parkinson's disease to begin with. And then if we give them an antipsychotic, we can worsen their risk of falls. Can also cause depression. And then obviously if we block D2 receptors, we get movement disorders. And we can also have endocrine changes. And of course, that is going to improve the treatment of psychosis. But again, in Parkinson's patient, it risks worsening the motor dysfunction. And then if we block serotonin receptors, if we block the 1A receptor, it's an anxiolytic. And if we block the 2A receptor, it's an antipsychotic effect. So you can predict adverse effects of various compounds based off their receptor profile. So we do have a study that looked at the receptor profiles, and this is receptor affinity. The lower the number, the higher the affinity for that receptor. So it's an inverse relationship. The lower the number, the higher the affinity. And these are common antipsychotics that are used to treat Parkinson's disease psychosis. We have pimavanserin, clozapine, olanzapine, quetiapine. That's the #1 antipsychotic in long-term care. Haloperidol and risperidone. And you can see that pimavanserin impacts the least receptors. Pimavanserin is selective primarily for the serotonin 2A receptor, which is what we think to be the beginning of the cascade that results in psychosis, with a little bit of activity at serotonin 2C. Clozapine, which is effective in treating Parkinson's disease psychosis and effective in treating all psychosis, you can see that it blocks every receptor that I just talked about. Olanzapine, it blocks most of the receptors. Quetiapine blocks fewer receptors, but it does block dopamine receptors, and particularly it blocks D2. So quetiapine is sort of a dose effect. The higher the dose, the more dopamine blockade there is. So in very low doses, it tends to be more of an anxiolytic, but we do see higher doses, and that anxiolytic effect, by the way, is from muscarinic blockade. But you can kind of look at these antipsychotics and you should be able to determine which one would make the most sense to treat someone with Parkinson's disease psychosis. So I mentioned pimavanserin, or Nuplazid, is the only FDA-approved treatment, and you can see that we had very statistically significant evidence in the trial for pimavanserin, which resulted in it getting FDA approval for Parkinson's disease psychosis. There was a 37% improvement in the psychosis. There were some individuals that had a complete remission. There were some individuals that didn't get a therapeutic response, but altogether 66% of individuals responded to pimavanserin, and there was over 1/3 reduction in their symptoms. And there was no impact on movement. You would not expect there to be any worsening of motor function because it doesn't block dopamine, and they actually proved it in the clinical trial. So we saw that pimavanserin had a therapeutic effect, and then in the open label extension of their trial, where we allowed people on placebo to get placed on pimavanserin, and that's the gray line at the top, you can see that over 6 weeks in the open label, the placebo arm almost caught up with the pimavanserin or Nuplazid arm in the trial. So even if you don't get to start treating the Parkinson's disease psychosis, or if they've been treating it with another antipsychotic that maybe is impacting dopamine and worsening motor function, you can start treatment with Nuplazid, with pimavanserin, and it will achieve its results even if you wait till a later stage to start treatment. But it does take a little while to see a therapeutic result with pimavanserin. It has a 57-hour half-life, so it takes about 2 weeks to achieve steady state. And while some individuals will respond earlier, you really need to give pimavanserin at least a month before you're going to see a change from baseline in most individuals that are going to respond. If you've given it for 6 weeks or 2 months and there has not been a significant change, then you would want to stop the pimavanserin and try an alternative treatment, because if they are going to get an effect, it should be noticeable by 6 weeks. And that's rather true of most antipsychotics. Adverse effects for pimavanserin are very low. They're very similar to placebo. The only adverse effects that were twice the rate of placebo were peripheral edema and hallucinations. And confusional state, not hallucinations. The hallucinations that happened were thought to happen because they occurred in that early 2-week period while pimavanserin was still achieving steady state. And almost every product that is under investigation for treating Parkinson's disease psychosis, we see hallucinations being captured as an adverse event because that is on the adverse event portfolio, but they generally are happening in the very beginning of treatment before the drug has had a chance to take effect. They also looked at sedation-related events and orthostatic hypotensive-related events. Again, you would not expect these with pimavanserin due to its binding profile, receptor binding profile. And in fact, we did see that there were less, it was either equal to placebo or significantly less than placebo for these events. So pimavanserin appears to be well tolerated, safe for most of our individuals with Parkinson's disease. Now, you do want to make sure that someone is not going to have an allergic reaction with Parkinson's disease psychosis. I do need to mention that pimavanserin and every other antipsychotic does have a boxed warning. However, pimavanserin or Nuplazid has a modified box warning. So every antipsychotic has the first statement: elderly patients with dementia-related psychosis treated with antipsychotic drugs are at increased risk of death. Pimavanserin, though, has a second sentence, and it says that Nuplazid is not approved for the treatment of patients with dementia who experience psychosis unless their hallucinations and delusions are related to Parkinson's disease. So if someone has Parkinson's disease and they have psychosis and they also have dementia, and many people with Parkinson's disease do have cognitive decline. They'll have a Parkinson's dementia, or they could actually have dementia of another cause, say Alzheimer's dementia, and also have Parkinson's disease. If their hallucinations and delusions are related to their Parkinson's disease, if they're similar to what I described earlier, then you can go ahead and still use Nuplazid, even if they also have dementia. So I think that's a very big distinction because only pimavanserin has that distinction. So as I mentioned, pimavanserin should not be used in people that have had an allergic reaction to pimavanserin. And while rare, it can happen: rash, urticaria, swelling around the lips and mouth and throat. So you would want to avoid that. If someone does develop an allergic reaction, remember that pimavanserin, with its long half-life, is going to be in their system for several, probably a couple of weeks. So we would want to do system support until the pimavanserin has worked its way out of their system. Pimavanserin also causes QT prolongation, like just about every other antipsychotic. It's actually a mild QT prolongation, and in general, does not cause significant concern, but the concern comes when you add pimavanserin to other drugs that also prolong QT interval. So I've got a few of them listed there: class 1A antiarrhythmics, class 3 antiarrhythmics, other antipsychotic medications, certain antibiotics. So any drug that can prolong the QT interval. If you want to start someone on pimavanserin, you should try to adjust other QT prolonging drugs before you introduce pimavanserin. If you do choose that to be the best option, then be aware that that QT interval can prolong. It's not required that you do EKGs before you start pimavanserin, but if you're going to add pimavanserin to other drugs that prolong the QT interval, you're going to want to know if there is an effect. Also avoid it if people have a history of QT prolongation, congenital QT prolongation, or arrhythmias. There are drug interactions because pimavanserin is metabolized by the CYP3A4. And so if you take pimavanserin with strong 3A4 inhibitors, you need to decrease the dose. The normal dose is 34 milligrams once a day. You need to decrease the dose to 10 milligrams once a day. And you should not give pimavanserin with potent 3A4 inducers because they can cause such rapid metabolism that you'll never achieve steady state. You will not get a therapeutic effect. So be aware that this is a big role for us as pharmacists because most of the time we have the opportunity to advise physicians on how to manage drug interactions and how to manage QT prolongation. So these are things that are right up in our wheelhouse, and being able to advise physicians on the best way to manage someone with Parkinson's disease psychosis can elevate our standing with our facilities and with our resident and patient care. So there are a couple of guidelines that we can go to provide guidance in treating Parkinson's disease psychosis. The ANN or ANA, the American Neurological Association, puts out a guideline that they last updated in 2019, which is a guideline on the treatment of movement disorders, and it has a specific section on Parkinson's disease psychosis. And they have reviewed all the studies available for treatment of Parkinson's disease psychosis that have been published, and they have determined that clozapine is efficacious. It is clinically useful for the treatment of Parkinson's disease psychosis. However, it does require specialized monitoring. You have to monitor for blood levels, and you have to watch for development of blood dyscrasias that can be fatal. So you have expensive lab tests, and you also have the risk of blood dyscrasias. Pimavanserin is the only agent that is considered both effective, clinically useful, and with an acceptable risk. Now, quetiapine is the most commonly prescribed antipsychotic in long-term care. It has insufficient evidence to support its use. There have been 7 clinical trials published with quetiapine, and in 5 of them, it was found to be equal to placebo, and in 2 of them, it was found to be equal to clozapine. So it's been questionable evidence about quetiapine, but that still seems to be the most commonly used product. And it's not supported by the compendia for use in Parkinson's disease psychosis. It is not supported by updated guidelines. The Beers criteria, however, does still support quetiapine. It was updated in 2023, and it basically says dopamine receptor antagonist with the potential to worsen Parkinson's symptoms should be avoided. The exception is clozapine, pimavanserin, and quetiapine, which appear to be less likely to precipitate the worsening of Parkinson's disease than other antipsychotics. Well, when it comes to quetiapine, that's a dose-related effect. So to get an antipsychotic effect of quetiapine, you have to reach doses of greater than 600 milligrams. And at doses that are considered antipsychotic doses of quetiapine, you can see that it is blocking significant amount of D2 and a lot of muscarinic and histaminergic receptors. So you will get more adverse effects at the antipsychotic dose. At the common doses used in long-term care, like 50 milligrams, it's more of a hypnotic. And at doses above 50 milligrams, it's more of an antidepressant. So the receptor binding profile of quetiapine changes according to the dose that's used. Oftentimes, we see quetiapine being used, given at bedtime in our long-term care facilities, or maybe even used in some of your residents that you treat in the retail setting. And 50 to 100 milligrams at bedtime is primarily a hypnotic. However, if caregivers and staff have been run ragged by someone with Parkinson's disease psychosis, with having delusions or hallucinations that frighten them, or they're being combative, and you can get them to sleep at night, a lot of people think that's a therapeutic effect, but it's not. It's a hypnotic effect. It's not actually managing the psychosis. We're just putting the individual to sleep. If we want to treat the psychosis, we need to select a drug that specifically addresses the serotonin 2A receptor and does not affect any other receptors to worsen motor dysfunction or cause other adverse effects. But this is our third question. We'll answer this in the chat. Which medications have demonstrated efficacy in treating Parkinson's disease psychosis? Is it clozapine, pimavanserin, quetiapine, A and B, or all of the above? So let me check the chat. Okay. Some of you got it right, and a couple of you thought it was all of the above. Remember, if I go back, the answer is D, which is clozapine and pimavanserin. If I go back to this slide, you'll see that quetiapine has not shown that it is, there's efficacy, because some trials showed and some trials, and most trials did not show efficacy. So clozapine is an option, but it blocks every receptor in the brain. But pimavanserin is an option, effective and selective for just the serotonin 2A receptors. Okay, so serotonin 2A receptor has been shown to be significant in mediating the psychosis in Parkinson's disease. And by acting via the serotonin receptor, atypical antipsychotics like pimavanserin help normalize glutamatergic and dopaminergic transmission in both the cerebral cortex and the striatum, so we can prevent the cascade of events that can interrupt or cause the psychosis without worsening the movement disorder. And we've got evidence of significance, so it may be an appropriate option. Now, remember, in the clinical trial, there were 25% of people that did not respond to pimavanserin, so having clozapine as another option could be useful. All right, so let me just end up with a couple of other slides about investigative medications for Parkinson's disease psychosis. These are trials that either are currently recruiting, are underway, or in the case of ulotaront, it has been completed. So sirvacatinib is an ongoing treatment. It's an SRC kinase inhibitor. This is a new mechanism, and they think that the SRC kinase inhibition will correct the serotonin 2A receptor. So it will reduce the hallucinogenic effects of serotonin 2A receptor agonism. Sirvacatinib is also being investigated for the treatment of movement disorders associated with Parkinson's disease, but in this case, it's being specifically looked at for Parkinson's disease psychosis, and particularly the visual hallucinations. Nelotanserin, very similar to pimavanserin, is a 5-HT2 receptor inverse agonist, exactly same mechanism of action that we see with pimavanserin, and it's currently in clinical trials, but it has not published the results of the trials yet. Ulotaront just completed their trial. It was a very small trial for the treatment of Parkinson's disease psychosis. There were 38 patients in it. They have published their results. Their results showed that there was a numerical reduction in the ulotaront treated group versus placebo. However, it did not achieve statistical significance. There was complete remission observed in 25% of the patients, but in the general responders, there was not statistical significance. So based off that one study, it's ulotaront will not get approval for Parkinson's disease psychosis. It may be considered for study at a later date. Now, those are the antipsychotics that are currently under investigation. Rivastigmine, which is a drug that's available generically to treat Alzheimer's disease and also Parkinson's dementia, is being looked at in a very small group for its effect to treat hallucinations and sleep disturbance. So it is being investigated, and you will see some individuals with Parkinson's disease psychosis will be on rivastigmine as well as maybe pimavanserin to help manage the psychosis associated, particularly hallucinations with Parkinson's disease psychosis. And then a new drug that is being investigated, which is currently in the recruiting phase, is high-dose levetiracetam, which is an anti-epileptic drug that we've known of. I mean, it's been on the market for 20 years, but this will be said high dose. It will be low dose levetiracetam, 220 milligram extended release tablets, and it's looking to improve the symptoms of general psychosis in Parkinson's disease. So that's what we've got on the investigative side. There's not a whole lot that's being looked at right now to treat Parkinson's disease psychosis. Fortunately, we do have an FDA-approved indication with pimavanserin, and we have clozapine as an option for people that do not respond to pimavanserin. A couple of other things I want you to consider. If you have someone with Parkinson's disease psychosis, there is sort of a protocol that we need to follow, particularly with our nursing home residents. If they are having symptoms of hallucinations or delusions, they do need a full medical evaluation. There are organic causes of the psychosis. It could be due to an electrolyte imbalance. It could be due to infection. It could be a psychosis that's associated specifically with dementia versus being associated with Parkinson's disease. So we do need to do a full medical evaluation to try to uncover the cause of the psychosis. And if there is no underlying cause identified, then the next thing we need to do is try to optimize their Parkinson's disease medications. We want to minimize drugs that are non-Parkinson's medication that can cause psychosis, like the use of opioids or the use of drugs with high anticholinergic profiles, because those can actually cause a psychosis. Then after we've minimized those drugs, we want to optimize their Parkinson's medication, because we do know that giving someone too much dopamine replacement can stimulate a psychosis. But we can't take all of their dopamine replacement away from them, or they will get very frozen and they will not be able to move, and there will be no quality of life. So that's why we have to optimize their Parkinson's medications. And usually we work starting with the dopamine agonists. Those tend to be most likely to induce a psychosis. So we may reduce the dose or perhaps remove a dopamine agonist. But in general, they'll still always be on levodopa, carbidopa, although you might need to be adjusting the dose. And once you've got that optimized, then if you do need to treat the psychosis, if they haven't responded to all these efforts, then starting with pimavanserin gives them the best outcomes in terms of reduced risk of adverse effects. And then again, we have clozapine available in our treatment basket. We have a lot of people that are treating Parkinson's disease psychosis with quetiapine, but again, at doses that are primarily hypnotic. The minimum data set that we use in nursing homes requires monitoring for psychosis and treating the psychosis either with non-pharmacologic means or with pharmacologic means if that psychosis is distressing. So obviously residents that are being combative or being afraid, if they are getting a negative outcome from their psychosis, would need to be treated. And usually it will require a pharmacological treatment. The psychosis, because it is a neurotransmitter imbalance, rarely responds to non-pharmacologic mechanisms. So we generally always end up having to add an antipsychotic after we adjust the other medications. People with Parkinson's disease psychosis, especially by the time they're late stage Parkinson's disease, may not report their symptoms. They may no longer have insight. They may not realize that what they are seeing is a hallucination. They may perceive it as real. They may not realize that somebody is not stealing their stuff. So we have to ask. And oftentimes if you ask the individuals themselves, they still will not give you a useful answer. So that's where interviewing the caregivers is very valuable. If you are a consultant pharmacist and you are in the facility, talk to the care staff, not just the nursing staff, but the CNAs that are with the residents, and ask them, does that person ever say something that makes you think they see things that are not there? Have they ever blamed you or someone else for stealing something, or do they feel that they're in danger? So those will give you cues as to whether they have Parkinson's disease psychosis. The last thing I want to mention is if we use an antipsychotic, then we have to do gradual dose reductions in long-term care facilities. And gradual dose reductions are common. Many consultant pharmacists, they just routinely will recommend that the physician consider a gradual dose reduction every 6 months. I will remind you that it doesn't have to be done every 6 months. It's every 6 months during the first year of treatment or during the first year in the nursing home, and then annually thereafter. However, Parkinson's disease psychosis is specifically mentioned in F758 in the antipsychotic regulation. It's expressly mentioned that it is a progressive and enduring condition that may need treatment indefinitely. And that's the sentence right out of the State Operations Manual. And therefore, they recognize that a gradual dose reduction could be clinically contraindicated, because obviously this is a continuing condition and it needs to be treated indefinitely. So it would be inappropriate to do a gradual dose reduction. Also, because there's only one dose. It's 34 milligrams unless you're on a potent 3A4 inhibitor, and then it's 10 milligrams, but it's just that dose. It's either that dose or nothing at all. So it's considered gradually or clinically contraindicated to do a gradual dose reduction. If they need treatment, you can continue treatment, but you do still have to document it in the clinical record. So the last question, which I hope you all get correct: Parkinson's disease psychosis may require treatment indefinitely, which would require documentation that a GDR is clinically contraindicated. Is that true or false? And everybody is getting A. That is the correct answer. So basically, everybody in the care of that individual with Parkinson's disease is involved in making the decision, do they have psychosis, and how best can we manage that psychosis? So I'm going to just drop us over to this last slide. We have 5 minutes and I can answer any questions, but I do want to remind you while you're thinking of any questions, and if you want to ask a question in the chat, I'll open that up in a minute, or so feel free to just put it in the chat if you'd like. But I'm going to remind you, we have some upcoming events. On May 15th is a 1-hour webinar, CE webinar. On May 24th is a 3-hour quarterly education series. The May 15th is our regular monthly, that's no cost. May 24th, there's a minor cost because it is 3 hours that will be available for consultant hours, or you can use them for general hours, whatever you would need. And then in June 13th and 14th, we have our in-live educational session for 2 days in Tampa. So we hope you can come to that. If you need any more information, you can scan the QR code. You can follow us on LinkedIn. You can follow us on Facebook. You can check out our YouTube channel. And by all means, you should be checking your email, because within about an hour, you're going to get an email from Lisa Starnes at AME. And if you get that email, you have to go to the link and fill out the evaluation and submit it in order to get your CEUs for this session today. So I thank you very, very much. And I see Lisa has texted her